Good morning, everyone. Thank you very much for joining us for this third webinar in our intense series, International Teaching for ENT Surgeons. My name is Aurelian Geru, and I'm the co-organizer of Intense. Today, we have a webinar on chronic rhinosinusitis, focusing on the allergic component. Just to remind you of our course overview, we have 6 topics with 6 webinars. The first part of the webinar will be focused on the UK patient journey, the gold standard of care for the topic pathology, which today is chronic rhinosinusitis. The second part of the webinar will be a discussion forum with our experts. And the third part, which happens after the session, is a reflective and evaluation form, which on completion, a certificate will be delivered to you. I'm sorry, I haven't got around to delivering the second webinar certificates, but those will be with you soon. As ever, please write your questions in the webinar chat, and those will initiate our discussion when we get to the forum. So without further ado, it gives me great pleasure to introduce our 3 rhinological specialists running this seminar. We have Liana Uduyani, Tarsa Moirin, and Mr. Martin Barnes, who is the clinical lead for Mid and South Essex Trust. Thank you very much.
Thank you for the kind introduction, Aurelian. Just going to share my slides. Okay, can everyone see my screen?
We can see your slides.
Yes.
Yeah, fabulous. Thank you. So thank you for having me, and good afternoon in Mongolia. I'll be speaking to you about the presentation and diagnosis of chronic rhinosinusitis, or as we call CRS. The content of this presentation is going to be mainly focusing on a guideline that we use in the UK, the relatively recent European position paper on sinusitis and nasal polyps 2020, which is a massive document, 400 pages, and it will have basically anything and everything you would want to know on the topic from their perspective. I'll talk a bit about the how we get to the diagnosis of CRS, because patients come to us, they don't come to us with a diagnosis or come to us saying that they have CRS, they have various symptoms. It's important to have a broad differential and exclude concurrent or other conditions. And then we'll move on to the diagnosis of CRS specifically using the criteria from this paper. And then I will just give an outline of the classification of what we call primary CRS, and then hand over to Mr. Barnes to talk about the management of primary CRS only. We won't be talking about secondary CRS for this webinar. So how do patients present? They will present with 1 or 2 or a few of these symptoms: a nasal blockage or nasal discharge, facial pain or pressure, loss of smell. But with each individual symptom, we do need to look at it and think, could there be anything else contributing to this that might hamper the management or need to be addressed separately? So, for example, when they say they have nasal obstruction, it would be important to check to see they don't have a concurrent septal deviation or nasal valve-related issues. You do the Cottle's maneuver as well as part of your examination. And bear in mind, if they have particularly unilateral symptoms, you may be potentially expediting any investigations as well, pending any comorbidities or risk factors that become apparent. Nasal discharge, it's important to ensure the patient understands what's going on with the nasal discharge, because later on, if you are going to be pursuing an operative course, the operation may not necessarily completely control this, particularly if there's an alternative diagnosis or a more dominant diagnosis such as allergic rhinitis or an underlying totally different issue such as CSF leak. Facial pain and pressure, and Mr. Barnes will touch on this as well, can actually be more commonly other neurological related causes, and it's important to also consider potential dental related issues, as these can also present with maxillary pain, particularly if it's involving the upper dentition. Epistaxis and itching, sneezy, watery eyes are not considered in the EPOS paper to particularly be chronic rhinosinusitis symptoms, but our patients may present with this as well, and it is of course important to address, again, particularly if the symptoms are unilateral. So what is the definition? Well, chronic is defined in this paper as 12 weeks or longer. Anything less than 12 weeks would be considered acute. And if there's a patient where they're having episodes of flare-ups of their nasal symptoms, but they have periods of normality in between, that's considered recurrent. The other important thing to remember is that, as we've alluded to already, we've said symptoms can represent a broad range of differentials. The paper is very specific that you can only say someone has CRS if they have the symptoms together with examination findings. So now I'll go through the symptom criteria and the examination criteria as well. So they talk about nasal blockage or obstruction and congestion, nasal discharge, which could be anterior or posterior, like a postnasal drip, facial pain and pressure, and reduction or loss of sense of smell. The reason why I put these two in brackets here in the picture is because it's important that they have 2 out of all of these symptoms, so 2 out of the 4, but they must have 1 of the first 2. So they must have either nasal obstruction or nasal discharge, and then another one of the others. In terms of endoscopic signs, you could see nasal polyps. So here we've got the inferior turbinate, the septum, the middle meatus here, and there is a well-defined homogeneous polyp there. They could also have a middle meatus discharge. So it's important to note that this is mucopurulent discharge, not just a clear discharge. It doesn't necessarily represent infection, but more what we call mucal stasis. So the mucus is static in that place, and the bacteria within multiply and give this appearance. Again, Mr. Barnes will explain the pathophysiology of this more in his slides. And also, it could be endoscopic findings, but you could also include the CT changes as part of this criteria. So here we've got a scan in the coronal view, and you can see that this is a picture of chronic rhinosinusitis without nasal polyps. So you can see the mucosal thickening in both sides and affecting the ethmoid sinuses here between the 2 orbits. And on this side, you can see the CRS with nasal polyps. I've just got a little zoomed in view here. You can see the thickening of the maxillary sinus and the obstruction of what we call the osteomeatal complex. And on this side, you can see this is a clearer pathway. It's important to note when looking at CT scans, actually, they suggest that if you only have 1 or 2 walls involved with thickening, and the patient's complaining of symptoms, it's unlikely to really represent rhinosinusitis. But again, Mr. Barnes will explore this in more detail. So what is primary chronic rhinosinusitis? Well, this is a disease that's considered to be intrinsic to the sinuses, i.e. not caused by something else, such, for example, granulomatous conditions or ciliary dysfunction, anything dental related or tumor related or immunodeficiency. These are all considered as secondary causes. So we're not going to talk about that today. We will just talk about the primary chronic rhinosinusitis. The newer classification suggests that it's anatomic distribution is the first point. So it will then be considered, you then look at to see whether it's localized or one-sided, as in this scan here, or diffuse and affecting both sides. Then they talk about something called endotype. So what is an endotype? An endotype is essentially a term given for a mechanism. So here, endotype mechanism, they then divide each into type 2 or non-type 2 inflammation. So from the patient sitting in front of us, we've got to the point already, we've taken their history, and from a history and an examination point of view, we, based on the criteria that I've mentioned, we have got a pretty good idea, a pretty good impression that they have CRS, but then we would then go on to do some investigations to further delineate whether it could be type 2 or non-type 2, so a blood test to look at whether they've got raised eosinophils, raised IgE. And we may also do a radiosorbent allergen test, looking for pollen, dust, mold, mildew, and dander. And this is what a lot of units do now for the common airborne allergens. And some places they still do offer skin prick testing as well. And these are just some examples of phenotypes. So phenotypes is, you know, what is the actual presentation and appearances that the patient has. And here we can see the different types that they would classify for each of these groups. So for example, if someone's got a primary localized type 2, they might have one of the presentations, there are others as well. It could be allergic fungal rhinosinusitis. And here, if they've got non-type 2, it would be isolated sinusitis. If they've got a diffuse bilateral type 2 disease, that could be, again, it could be allergic fungal again, because that could affect one side or both sides. But there are other conditions such as CRS with nasal polyps, eosinophilic CRS, or central compartment allergic disease. And finally, non-type 2 bilateral diffuse CRS you could also have non-eosinophilic CRS. So that's up to the point of diagnosis. I'll now hand over to Mr. Barnes to talk to you about the management.
Thank you, TK. That was nicely done. I'm just going to share my desktop. So can someone tell me if you can see that?
We can see that. Thank you very much, Mr. Barnes.
So I'd like to start actually by getting a little bit of a feel for our attendees. Can you all open your chat and maybe just type a 1 and press return if you're hearing me and you're able to talk? Let's make sure we're all actually tuned in. I'm an ENT surgeon based in the UK. I'll give you a moment to get that sorted. I've been in post pretty much for 10 years now. Before that, I did fellowships across the world. I spent some time in Adelaide, and in Auckland, I did my main fellowship. I did facial plastics fellowships in Amsterdam as well. And my main interest is sinonasal surgery on an ongoing basis. Seems nobody's talking to me. Just put anything in the chat just to know that you can. If not, we'll make it a fairly didactic session. TK's already given you a talk about presentation and diagnosis. I'll give you a talk about management and the pathogenesis that really defines the management, I hope. So this is actually a talk that I have given in the past. I have significantly modified it, but to our local GPs. And so I thought it was worth leaving my title, which was to dissuade them from their preconceptions that chronic rhinosinusitis is everything to do with the patient presenting with headache and facial pain. It really isn't. Chronic rhinosinusitis is not the typical thing that you've seen in the media in years gone by. It's not the patient presenting with severe frontal headache, etc., etc. It's more about constant blocked snotty noses and loss of the sense of smell, etc. And the nature of chronic rhinosinusitis is a bit of an enigma. It's a bit like asthma. We don't fully understand the pathogenesis of it. We don't really understand why people get it. We don't fully understand the best ways to treat it, etc., etc. But we're making steps, step by step. And the papers that TK was alluding to, the EPOS guidelines, is maybe the most extensive and scientific summary of our understanding to date, and well worth engaging with. There's been all sorts of theories in the past about the etiology of it, and early studies looked at whether it was associated with allergy, for example. The overall consensus would be that it wasn't really. There's certainly a few quirky immunological issues that can be associated with CRS. There's very definitely cilial issues that can be associated with with CRS. In fact, I think, to my mind, the disease comes down to this thing at the bottom, a failure of mucociliary clearance and all the pathological consequences of that, and that's most strongly evidenced by the strong associations with CF and with ciliary disorders, etc., etc. But there are also associations in one way or another with I think there have been some anatomical features. Certainly there have been a lot of studies into the presence of microbiome microorganisms, and there are some very interesting studies coming out of Auckland with regard to polymicrobial infections, for example. Well, infection isn't the word. Shouldn't really use infection, because we're already using far too many antibiotics on these things already. And it's not the nature of the disease. The nature of the disease is that the sinuses get blocked, and that causes mucus to dry out, and a pathway that includes microorganisms, but I would encourage you not to think of those as the out-and-out cause, although you never know. Sooner or later we might find that there is one specific microorganism that is in some way related, but I suspect not. I think this can be polyfactorial. And in many ways, it can also be degenerative. This is a progressive sequence of events that leads to the pathology that is CRS. There's certainly been studies showing the presence of biofilms, but you can show biofilms in lots of different places. There's certainly some examples where superantigens and staphylococcal infection and intramucosal microabscess formation and the likes are certainly implicated, but we don't fully understand why there are some of these, and then there are others that don't have any evidence of this. And as TK showed, we're beginning to break down our understanding of chronic rhinosinusitis into a lot more diverse types of diseases that are actually distinct, and that's even without looking at things like dental disease, which presents very differently. You know, a dental root collection spreading into the maxillary sinus, leading to maxillary problems, and then blocking the frontal recess and giving you unilateral. Whenever you see a patient with unilateral sinus, chronic sinus problems, ask yourself, you know, could there be a dental factor involved here? And it's only really in the last 10, maybe 20 years that we've begun to sort of regularly recognize these the dental element in many of these things. Still nobody talking to me at all. Post something in the chat if you're able to. I don't know if there's some technical problem with that, but it would be really good to know at what stage you're at with your surgery with regard to the sinuses in particular. This is a fairly mild case of CRS. It does show some pan sinus thickening, you know, but it's pretty mild as these things go. So it's also essential in our management of these patients that we fully understand the anatomy of the sinuses. And I encourage you to study scans very much. We'll talk about that a little bit later. So we're all familiar with a normal nose. Unfortunately, it will not let me scroll through these as I would like to. But what are we looking for in a patient with chronic rhinosinusitis? We are getting some posts, I'm afraid. I see. Okay, so maybe your written English isn't so good as your understanding. But anyway, I will continue to teach passively. So the whole nature of this disease is that things get blocked off. You get this, that, you know, there will be microorganisms involved in this mucopurulent discharge, but they're not the fundamental cause. And there's this whole spectrum of chronic rhinosinusitis, which I think the previous understanding that this was a spectrum between mucopurulent disease and polyp disease still holds value. You can get a little bit more sophisticated than that, looking at eosinophils, looking at neutrophils, looking at a lot more than that increasingly. But I want to teach you a sort of pragmatic approach that will serve you well in your general ongoing management. So as TK has already spoken about the diagnosis, now this is the diagnosis that is advocated based on symptomatic diagnosis, which is given to apply to any doctor essentially, and for use in primary care. But we often have a lot more sophisticated ways to come to this diagnosis, and bear in mind there are other broader symptoms that can be involved, especially in allergic spectrums of the disease, especially when there are surgical complications and other things like this. But don't underestimate it. You know, chronic rhinosinusitis is commonly associated with oral and with ear problems as well, and so it's not too unusual in some of our more severe patients to see glue ear or even chronic suppurative ear disease with a perforation and constant discharge, and even polyps seen in the middle ear, etc. So, of course, also bear in mind the differential. And so when you're looking at a patient presenting in clinic, the tools that we have will greatly facilitate you ruling out a whole host of other diseases. And so allergic rhinitis, this is a nice picture of how easy it is to get confused. You know, you might look in this nose and think there's an awful lot of discharge. It's really quite congested. You could even look in here and think that was a polyp forming, but this is just allergy. This is the typical changes of the inferior turbinate, blue, white, thickened, all these sticky strands, and more mucoid discharge rather than mucopurulent discharge. And this is after simple decongestion. So in fact, let me play it through. I've literally just sprayed this nose, and you can see the effect of the decongestant opening up as we watch until you can see right the way to the middle turbinate. And then you can more clearly see that that isn't, you know, polyps, that there's no mucopurulent discharge. Other things are important to be aware of as well. So structural disease, anything like mucosal swelling and thickening and hypertrophy of the inferior turbinate, but also, as I was alluding to back here, the septum itself can be responsible for a number of the symptoms. And bear in mind, if you've got structural disease, you need to treat that as well, because it's going to not only give them nasal blockage, but it's also going to prevent their medication delivery, which we'll get onto is one of the most fundamental factors in their ongoing treatment, potentially lifelong treatment. And don't forget that, especially in the case of allergic patients, they can often retain hypertrophied adenoids. And so this was a case where we got to theatre to do a simple septoplasty and turbinate surgery, and realised in the middle of the operation that maybe our diagnosis from clinic wasn't actually quite right, because they got significant adenoid hypertrophy, and maybe that was the more important thing to address. Just a few other things, we do see the odd tumor, we do see complications of surgery with perforations in the septum. This is a nice picture that shows you a turbinate reduction. Actually, you can see that this inferior turbinate does not go anywhere near to the floor of the nose, and you can see an awful lot more space, although there is this complication. I'm not sure if this was my own patient, possibly not, but there is this complication within the septum with a septal perforation. But nonetheless, this patient will have much improved medication delivery following the surgery they've had, assuming they're a CRS patient, which I can't actually remember. But so getting back to what I think is the fundamental thing you need to understand about this disease in order to understand the treatment is that this is a sequence of events that they go through where, for one reason or another, it may be allergy, it may be something genetic, it may be some infective episode that's caused some damage and some compromise of the mucociliary escalator. I should say this is maybe a term that you're not necessarily familiar with, but the whole lining of the sinuses is that the surface of the lining is covered with ciliated cells, which have a constant beating action that push mucus, and there's mucus glands again throughout the sinuses. There's about 1 litre of mucus produced within, at least 1 litre, produced within the sinuses every day. And that naturally moves on a really thin conveyor belt on top of the surface of the mucosa, passing out of all the sinuses. And you can actually map the passage of mucus from the frontal sinus, exactly where it goes, from the maxillary sinus, from the ethmoids and sphenoid, and you can track it, and it flows into the throat, and every now and then we swallow, and that clears things, and that's in a healthy state. But when that gets compromised and the mucus isn't flowing, or there's blockage, that's when you get some problems. And that may be an acute episode of sinusitis, but when it fails on a more permanent basis and things are just accumulating and blocked and drying out and becoming sticky and becoming edematous, and some bacterial infection, not infection, I hate using that term in this disease, some bacterial presence exacerbating things and causing more inflammatory response, which again is harmful, as it often is, then you wind up with a blockage and a vicious cycle that just gets worse and worse. And that, to my mind, is what CRS is all about. And so how do we treat that? Well, how do we reverse these inflammatory changes, edematous changes, some infective elements, failure of the mucociliary system? How do we? It's a complicated thing to actually tackle. We can aim to unblock the sinuses. We can certainly do that surgically. We can use decongestants, but you can only use decongestants for a few days, and take it from me, that's not really going to change much. Otherwise you get rhinitis medicamentosa and you make things worse than ever. But can we reduce the inflammation? Well, that's certainly one of the avenues we pursue, and steroids, and for that matter the more modern biologic treatments, which I don't really have access to, but they certainly show some promise. These are direct approaches to tackle it in that way. Can we clear the inflammatory secretions? Yes, we can. Simple things like saltwater washes. So it comes down to, in my mind, 3 main things: corticosteroids, saline washes, and surgery. And so The corticosteroids will calm down the inflammation and any edematous change. Saline washes will help to wash out inflammatory secretions, and surgery will help to unblock sinuses and not only open the sinuses for drainage, but also to facilitate medication delivery. Now, I'm getting a note saying that there's 15 minutes per person agreed. As I understand it, we have half an hour left to go, and this is going to be probably the bulk of the talk. So I'm going to carry on for another 5 minutes anyway, but tell me if that's if you feel that's wrong.
Martin, we'd also like to leave a good 20 minutes for Q&A discussion with you.
Okay. That wasn't exactly what we planned, but I can rush through the rest of it.
Sorry about that.
Okay, there are minor uses of other treatments, but on the whole, they only have, very limited use in specific scenarios where specific symptoms are involved. I think I've already alluded to the fact that facial pain is unlikely to be related to chronic rhinosinusitis. It may be more related to acute rhinosinusitis. It may be related to migraine, and excuse me, and it can certainly be related to a dental disease. But so I'm not going to go into that. Whenever you decide to progress to surgery, I encourage you to think about the balance of risks and benefits. And at the end of the day, you're not going to cure anyone of the disease, but extensive surgery can certainly have significant beneficial effects. And you can have a look online if you want to see. I've created an educational video on the types of surgery that you can do if you have the experience and the equipment to hand. Which might just give you a feel for what we're trying to achieve with surgery. In a good case, having done extensive surgery, this is the sort of thing that you can end up with. So that's the view to the sphenoid septation. This is the ethmoid cavities, the maxillary sinus, and you can see up to the frontal, all widely patent, and no evidence of mucosal edematous change and thickens and blockening. We'll skip over the complications. I would emphasize that if you're going to do surgery, the most important thing is that you understand the anatomy, and particularly the anatomy of the patient you are operating on there and then. And so do study their scans and make sure that you've spent some time studying scans in general, studying 3-axis radiological imaging. Maybe have a look at some of our resources on our website, looking at this is a micro CT scan of the sinuses, showing you the way up to the frontal sinus. This 3D model that we've got, more virtual endoscopies, and that's us. So just to emphasize, going back to the fundamental management, we are talking about corticosteroids, however you deliver them, on the whole topically and lifelong, saltwater washes, and surgery as an adjunct in order to allow drainage and to facilitate medication delivery. Name of the site is surgetech.net.
Thank you very much, Nick. Liana, do you want to take over?
Yeah, I will share my slide. So thank you for that nice talk, Mr. Brain. And I'm Liana Udiani. I will talk to you today about prevention of chronic rhinosinusitis. As you all know, in any disease, prevention would be better than cure. So can we prevent chronic rhinosinusitis? Yeah, it's a good question, and hope you will have an answer at the end of my lecture. So why do we need to prevent chronic rhinosinusitis? It's a disease with significant health problem and affect a patient's quality of life a lot. And there's about 5 to 12% of general population is having chronic rhinosinusitis, and it's a quite common disease among population. So in my lecture today, I will discuss it in three broader topics. We will discuss about primary prevention, secondary prevention, and tertiary prevention. First, I will discuss about the primary prevention. In the primary prevention, we try to reduce the incidence of chronic rhinosinusitis by reducing the exposure to risk factors or triggering factors. But I will not go to talk more about risk factors and pathogenesis, as Mr. Barnes has already discussed it. most of these risk factors have not been proven. Some they have been proven. So when we consider the smoking and CRS, there is a strong evidence it as a risk factor, and CRS is more common among smokers, and even passive smoking in childhood will increase the risk in adulthood. So what we can do for prevention? We should always advise the general population as well as the patients on stopping smoking, and we should always refer them to the smoking cessation centers, and as a government policies, we can increase taxation and it may help in stopping smoking. Is there any relationship between allergic rhinitis and CRS? It's not proven well, but there's some weak evidence that treatment of allergic rhinitis will improve the outcome of chronic rhinosinusitis. And as ENT surgeons, we also have experienced the benefit of effective treatment of allergic rhinitis. So we should always try to optimize the allergic rhinitis treatment in these patients. And odontogenic infection is a non-risk factor for CRS. So we should always try to educate patients regarding good oral hygiene, and we should advise them to seek dental care when they need it, and we should refer the patients for dental facilities if we think the cause is odontogenic in origin. And is there a relationship between occupational and environmental irritants or pollutants with CRS? Yes, it is. There's a growing evidence regarding this, and occupations like farmers and textile industrial workers will have a higher risk of CRS. And in some research, they have shown that particulate matter exposure will increase the disease severity, and they will ultimately need an endoscopic sinus surgery as a management. So how can we prevent this sort of occupational exposure to irritants and pollutants? So if the patient or person is exposing to such exposure, we should always advise them to use proper personal protective equipment. And to prevent global pollution, environmental pollution, we should address a global action. And there's a recent evidence to suggest there's an association between gastroesophageal reflux disease and CRS, but there's no evidence to suggest that treatment to GORD will improve the CRS. My next main topic is the secondary prevention, which is very important to us as ENT surgeons, because in the secondary prevention, we mainly discuss that the patient in the society will have the disease, and we will always try to reduce the disease prevalence by early and proper diagnosis of the disease. And then we have to control their symptoms with proper treatment, and we should prevent future exacerbation, and we should prevent chronicity of the disease. So this is the most important part to us as ENT surgeons. So we should always try to prevent disease being a chronic disease. So I will discuss it in few aspects. So to have a good secondary prevention, we should have better diagnostic tools, and this will allow us to have a early and correct diagnosis. And chronic rhinosinusitis, as my colleagues mentioned, is an umbrella term with a lot of subtypes, endotypes, and phenotypes. So care should be personalized for the individual. Otherwise, it will not going to prevent the disease being a chronic one. And when we are treating the patient, we should always try to identify the patients who have poor disease control, and we should escalate their care. And we should plan timely surgical interventions. And there's a lot of evidence towards that if we delay the surgery, the patient's outcome will be poor. So if we are planning a surgery on a patient, we should do it early as possible. But this does not mean that every patient with CRS will need a surgery. So we should always select the proper patient and do the surgery early as possible. And there are new treatment options as biologics. So we should identify the patients who will need these. Most of the patients who will fail to respond to conventional treatment may benefit from these with type 2 disease. So we should select this group, and we should start them on biologics as well. And last part of my lecture is the tertiary prevention of chronic rhinosinusitis, in the tertiary prevention, we talk about the patient who has a chronic disease. And when the patient has a chronic disease, we should always try to reduce the impact of ongoing chronic disease, and we should try to reduce its complication as much as possible to maintain a good quality of life and normal function as much as possible. So there are various factors will lead into poor disease control in CRS. Some are disease related, like genetic and endogenous factors, which is difficult to have a control with, and some are diagnosis related. It may be incorrect diagnosis as facial pain, as Mr. Barnes has already discussed, so I'm not going to discuss more about it. So we have to identify any other systemic diseases and treat them as well. If the treatment is incorrect or inadequate, patient will have a poor control. And in the patient's related factors, our patient can have a poor compliance with the treatment, and they may have recurrent exposure to these toxic environmental pollutants. So how can we minimize the complications of treatment? This is important because these patients will have long-term treatment. We use intranasal corticosteroid as a mainstay of management in CRS patients. And we should always try to use a steroid with a minimal systemic absorption, like mometasone or fluticasone. But we see a lot of patients are using beclomethasone-like preparations because they're cheaper. But the problem with them is they have higher systemic absorption and can have systemic side effects. When patients use saline rinses, we should ask them to avoid contamination of it. And when we prescribe oral steroid, we should use it in a safe manner. And patients with chronic rhinosinusitis without nasal polyps are being treated with long-term antibiotic courses like macrolides. But there is a proven evidence that macrolides can increase the risk of myocardial infarction and arrhythmias. So when we try to prescribe those antibiotics, we should weigh the benefit versus risk and select the proper patient. If you are planning a surgery, we should try to minimize the risk because of the surgery. So we should better select the patient, and training of surgeons is important to have a better outcome. And advanced instruments usage will help us. And we should try to have a good surgical field, and image guidance may help, but it is still not proven with researchers yet. And if the patient is having other comorbidities like depression and anxiety, however we treat them, they will have a higher symptom score. So we should always try to treat other patient comorbid diseases with the CRS to achieve a good outcome in these patients. So what are the advice that we can give to a CRS patient? We should always advise them to avoid risk factors, and we should advise regarding controlling the other comorbid diseases. And drug compliance is really important. We should always tell them that this is a disease that we cannot cure. They should know that it is only a disease that we can control. So to achieve a good control, they should have a good drug compliance. This thing we should always educate to the patient, and proper usage of drug technique is also important. And if we are prescribing steroids to them, especially oral ones, we should advise them on side effects, and we should advise them on when to seek medical care if they develop any side effects. So a few words about how to apply a nasal drop properly. In this image shows this is not a good technique to apply a nasal drop. It will directly go to your postnasal space and to the throat. So these three positions are better positions for application of nasal drops. And I will run because time is running. This is a position to apply a nasal spray, and you should tilt your head forward, and it's better to use your opposite hand to apply the nasal drop to each nostril. So you should direct the spray towards the lateral nasal wall, not towards your septum. There are various ways of doing saline rinses, irrigation, or douching. So sometimes patients will have a poor drug compliance because they cannot afford it long run. So we can advise them on how to prepare homemade sinus rinse. So then we can improve their compliance. And we should always advise them how to do a proper saline rinsing and all. So all these methods we can try to prevent this chronic disease going into a disease that we cannot control. So that will end up our talk. And thank you for listening. And then we'll move to our question and answer sessions.
Thank you very much, Dr. Udayani. So now starts our Q&A session. We only have 14 minutes. We have our first question from Dr. George Suren from the Intermed Hospital in Ulaanbaatar. What is the first-line surgical treatment for chronic hypertrophic rhinitis in the UK? Maybe one for Mr. Barnes and Mr. Ainan Lewis, who's also joining us for the Q&A session.
Well, I don't think that's a diagnosis that I would specifically label chronic hypertrophic rhinitis. So if we're talking about chronic rhinosinusitis, then first-line surgical treatment for me would be clearance of any polyps and what I would call a mini fest. So often a lower half uncinectomy, take down the bulla and any other cells that are easily exposed. But that would be for CRS. If we're talking hypertrophic change in the turbinates, then I'm increasingly encouraged to look at turbinoplasty, although my traditional technique has admittedly been an anterior third turbinate reduction, a simple turbinate reduction and careful monopolar diathermy to it. So, Nick, good to see you.
Hiya, how you doing?
Do you have any thoughts on that?
Well, firstly, thank you to the three speakers for fantastic talks, really excellent. So turbinate surgery, I'd be interested to know what the view is in Mongolia, really, if somebody can feed back on us, because it's always been an area of debate, and it strikes me that there's a sort of little what we might call cottage industry in doing turbinate surgery, certainly in Europe and the UK. And you have a blocked nose and you go along and somebody will shine a laser at your turbinates, or they'll do something or other and tell you that's going to improve your breathing in your life, and sometimes it might do. And there's a long debate about turbinate surgery and rhinitis, and I think there is a place I've tried sort of all various different things over the years. I think there is a place for turbinate surgery. I think what is interesting is that certainly the trend in Europe is to be conservative. So we still see patients with a large amount of inferior turbinate removed, and some of these patients are absolutely fine and they have a fantastic airway and they're very happy. And sometimes you see patients that are very unhappy because it seems to do something to the sort of normal physiology of the nose and can cause all sorts of symptoms. And there is something called empty nose syndrome, which is very controversial. We won't start going into that now. So can anybody feed back to us with the Mongolian experience?
Gan is a rhinologist, so Gan, can you jump in for us? Do you do a lot of turbinate surgery?
First of all, it was a great talks from the old speakers that was including the proper and very well structured instructions to the all attendees. Thank you for that. And the question, the major problem that we're encountering with the hypertrophic inferior turbinates we're dealing with is the most of the procedure is mostly done on the tertiary care hospital, because the hospital that can provide some surgical services is only based on tertiary care hospital. So they're all like just 4 to 5 hospitals, something like that. But what they do mostly is not like a turbinoplasty thing. It's just a partial turbinectomy. So, which can be the cause of because it depends on the patient's symptoms, because I'm actually the same idea with Dr. Nick, because some of the patients is very happy with the partial turbinectomy, but there's some the minor of them is unhappy with that. They're showing some symptom with the empty nose syndrome, something like that. But now we are having some problems that we're not only facing with just say turbinate hypertrophy, which also including allergic rhinitis. That is the main issue that we have to deal with, because if it's some concurrent issue, it's not, there's some significant management just for the chronic rhinitis. It can be changed and pop into just some extra management. So now we're just have a dealing knowledge gap between the, especially doctors who's working on the tertiary care or secondary care hospital, because we have some knowledge gap, because the patient with some suffering the same issues, if they're referring to the doctor, secondary care hospital, they're talking to the patient one thing. If they go into the another doctors who's working at the tertiary care hospital, they also talk another level of thing, like way much different, something like that. You know what I mean? So that's why I'm talking about some knowledge gap. But the thing that we do mostly, the conceptually, is the same as we do right here.
And what do you think are the main differences in practice between you at First Central Hospital and UK practices that you've heard about today?
For me, I would like to talk more about this CRS-based issue, because the CRS issue is prevailing issue in Mongolia within the upper airway respiratory disease. Also, these talks, I'm very happy that the speakers, they mentioned the CRS can be divided into the vast variety of the some characteristics, including, at least it can be divided into 5 to 6 subtypes. Also, I'm very glad to mention that the variations can have its significant pathways, the immunology pathways. So that subtypes can be also managed by its significant management. Also, most of the subtypes can cause by.
I'm going to cut you off there again, just because we're running out of time and we're getting some great questions through the chats. So back to our UK panel. How do we select the patients that we need to undergo surgery? How do you do your patient selection?
That's a really good question, because based on the issue from the speakers in the talks, in Mongolia, we have some lack of introducing the patient what you have really has, because the lack of introducing what they have is very specific, because if the patient informed very wrongly or just insufficient information about what he has or what she has, afterwards it will be a problem, because some of the subtypes of the CRS can be recurrent or recalcitrant,
Mr. Lewis, how do you select your patients for surgery? Sorry to cut you off, Gan.
Well, I very much agree with Martin that you need to, with any operation, you need to balance up the potential benefits from the potential complications. And I think I think Farsika said something very useful, that I say to patients that essentially this is a medical condition where there is a place for surgery, and the studies show that there is a place for surgery, but I may not be able to, cure you as such. I mean, I think very often the patients where they have terrible disease and polyps and all the rest of it, you're not going to cure them really. You may relieve their symptoms. Sometimes it comes back very quickly, sometimes it doesn't. You actually get a good result from that. Patients where there's minimal disease, you're thinking, well, it's probably you're not going to make a big difference. It's probably mainly rhinitis and etc. And I think the ones in the middle somewhere, where they've got what looks like significant opacification, and you have a chance. I think you can potentially cure them, if I'm allowed to say that, with surgery. I mean, I wonder if I could ask Martin, because it made some interesting points about infection and I think bacterial colonization as opposed to infection maybe, but whether he sees a place, whether he uses antibiotics. I think that's quite an interesting question that might also relate to Mongolian practice.
Very rarely, Nick. I have used, I mean, I should make the proviso that there is good evidence that macrolides in certain circumstances have an anti-inflammatory activity, which is not to do with an antibiotic effect. And especially in, now I'm going to get this the wrong way around, in neutrophil prominent disease. With that one proviso, I don't really see a great role for antibiotics in these cases. Now, bear in mind, we're dealing with a complex variety of disease in some of these cases. So someone might be dental, then they might have more of a role for antibiotics, although to be honest, I still go for surgical drainage on the whole. There was one patient where I was tempted into an antibiotic treatment regime by the microbiologists because somebody had sent off a microbiology swab, and he was an interesting patient who had some borderline immunodeficiency. He had a previous brain abscess secondary to a knee infection and septic arthritis of the knee, and so he was an odd chap, and he had an odd organism. And the microbiologist said, oh, you know, we should treat this. And he wound up with a PICC line for several months with a really exotic antibiotic. And he came back and he felt a little bit better, as they do. You know, giving antibiotics does calm some of the stuff down and they feel a bit better. But then 2 months later, he got the same bug back again. And we went through 2 cycles of this on almost the insistence of the microbiologists until I had him in clinic. I said, look, you know, really, this is an odd bug, but it's not doing anything unusual. It's doing exactly what crusty chronic rhinosinusitis patients often get. And we stopped talking to the microbiologist and just managed him as I would a typical crusty chronic rhinosinusitis patient. They're some of the most difficult ones, actually. Polyps you can always do something about, but when you've got someone who's starts off with a really mucopurulent disease and then they just turn into a crusty maxillary cavity and you think it's chronic infection, maybe it had a dental origin, but it's bilateral, so maybe not. And it really did him no good whatsoever. So yeah, that's my thoughts about antibiotics.
Thank you very much, Mr. Barnes. Thank you to all our speakers. I'm sorry we had to be so strict on timekeeping, but unfortunately the ENT Zoom account is being used at 9. That's why we're very strict to schedule. Please, all our attendants, complete the feedback form and the reflection form, which is now posted in our chat. And I can share my screen. I can't, but it's the same link every week, so you can get it through GAN as well. Brilliant discussion, brilliant talks. Thank you so much. And hopefully see some of you at our next one, which I think is next week on Wednesday, back to Wednesday again. All right, thank you very much for joining. See you next time.